I really enjoyed the talks this morning, I have to say, first of all, because I think they illustrated a little bit of what I was talking about yesterday, that you can be relatively technology agnostic, but the concepts of how we achieve adequate focal ablation are very overlapping. I particularly enjoyed Dr. Pavlovich's comments about how with the TULSA technology, they tried to evaluate why it didn't work and what were the reasons for failure, and modified the technique and the technology, and that's really what we need to do. So my comments here will really be on general mechanisms of why people recur after focal therapy, how do we mitigate the risk, and how do we manage it when it happens. And so let me start by saying, why does focal therapy fail? Well, in theory, it fails for one of three reasons: inadequate local ablation, so we would call that in-field failure, and that's recurrence of the treated tumor. It may recur because of disease biology. That would be multifocal recurrence within the gland and a tendency for the disease to come up in previously non-malignant areas. It may fail because of poor staging, candidate selection, and that may be the rare cases where we see metastatic recurrence. This slide I showed you yesterday because I think it's hard to separate factors that might contribute to failure. Some of them are technique related, some of them are candidate selection related, and of course, some may be related to the energy source itself. One of the challenges is, how do we define failure? And this has been a particular challenge when we design clinical trials that we present to the FDA. It's clear that the best metrics would be those in red: metastasis-free survival, cancer-specific survival. That's really how we would show benefit. But of course, given the length of those studies, the size of those studies, and the difficulty in defining a correct comparator, most of our data relies on things like recurrence-free survival, which would be any cancer, significant cancer-free survival, which would be any pattern 4 in most people's definition, or progression-free survival, which I personally feel is the benchmark for true failure of focal therapy, worsening disease features over time. Many of us are starting to think of focal therapy as a long-term management strategy rather than a single intervention to be compared with prostatectomy because of the ability to retreat. Now, this is a small data set of a small phase 2 trial I did about 10 years ago using focal RFA. But I illustrated really, the thing on the left, Ezekiel Betcher designed a diagram we use to follow the individual patients and interventions that occur along the way. Green means they remain free of cancer, yellow means they have indolent cancer, and red means concern. But if you look on the right, looking at all those metrics for success or failure that I outlined, they vary greatly. So even at, in this case, 79 months of average follow-up, you can see that metastasis-free survival, cancer-specific survival, are sort of meaningless because of the group we selected, and we really rely on things like need for repeat ablation, disease-free survival within that time period. Forms of failure are generally divided into those that are treatment zone related, so in-field recurrences. This could be due to incomplete thermal effect, non-confluence in the treatment zone, and often can be treated with repeat ablation. Margin failure, which is difficult to distinguish sometimes from treatment zone failure, and I'll explain why. That may be due to inadequate size of ablation, inadequate margin, and also is a candidate for repeat ablation. Failure outside the treatment zone may reflect disease biology. It may reflect a lesion that was missed on the first MRI, but always there all along. And extraprostatic recurrence is perhaps the most challenging and the thing that we fear the most when we select candidates who are higher risk. I alluded to this yesterday, that I think there are critical concepts that overlap in all of the thermal energy sources we use, and even some of the non-thermal, and I call these thermal dispersion, thermal confluence, thermal gradient, and thermal sink. Thermal confluence really relates to some extent to the idea of in-field failure. I'll show you examples of these. So the thermal dispersion concept comes if you have a tumor in the peripheral zone, as an example, and you treat it, So the energy will spread beyond the treatment. And in some energy sources, in order to get adequate ablation, it's inevitable that you will have some degree of thermal cooling or heating beyond the treatment zone. That halo can be larger with some energy sources. And so we mitigate that risk by making smaller treatment zones that typically overlap. So as an example, using multiple cryoneedles instead of a single cryoneedle can reduce the size of the thermal dispersion halo. So common treatment failure might occur in the left if those smaller treatment zones are non-overlapping. That would create non-confluent undertreatment, and that occurs with delivery of small treatment zones. Sometimes in the case of HIFU, as an example, if the gland swells or shifts, you may see gaps in the treatment, and that can contribute. It's not clear if fusion helps because, of course, if the gland is changing during treatment, fusion continues to become less and less accurate during the course of the therapy. Margin failure can also occur with this strategy of small treatment zones if it's not targeted properly. So if you align the treatment zones over the tumor, but not quite to the edge, then of course you may see a margin failure along the edge. Thermal gradient refers to a loss of energy from the energy source. So cryo is a good example of this. We aim for a -40 freeze, but of course there will be radial decrease in the temperature as we go out. And if that radial decrease reaches a non-lethal temperature within the intended treatment zone, this will result in failure along the edge. Additionally, the presence of a warming catheter then can cause what we call thermal sink with an area that is hard to cool if in fact your energy source is too far away. This could apply not just to cryo, but of course to HIFU or other heating thermal energies if, for example, you're very close to the bladder, which is an insulator, and the urine can diffuse the heat, or venous structures with running blood within them, which may diffuse the heat. So thermal sink is another anatomic consideration when you're selecting treatment or planning it. Now, planning of treatment becomes important. I've repetitively said that I tend to use a 10 millimeter margin, but of course, it incorporates around the margin consideration of the biopsy characteristics. So here we've got a targeted biopsy with 3 red cores that are positive, and then an adjacent red core that's positive. So of course, our margin would need to be extended. You heard a little bit yesterday about how I do the treatment planning. And I try to work to make sure that we are quite generous in that treatment zone application. And of course, you guys heard this morning that in all the speakers' talks that there's a pervasive belief that larger ablations, as long as they're not causing more toxicity, may be beneficial to the patient from an oncologic perspective. Now, yesterday, I think there was a mention of, and I think there'll be talks about it later, but there's a new tool that's just been 510K cleared, I believe, from Avenda Health, which I think represents perhaps to some extent the future of how we will plan treatments in focal therapy. It's an integration of MRI and biopsy and pathology, as well as the spatial distribution of the biopsy on computerized templates generated from Fusion platform and clinical parameters, and it goes into a machine learning model to create a predictive heat map of the spatial distribution of the disease. And that heat map can be varied according to what confidence level you wish to achieve. So here's an example of a biopsy overlaying an MRI on the left with positive cores, the Unfold AI, which is the name of the tool, its prediction, and then how that relates to whole mount pathology. This is an example of the 10 millimeter margin being perhaps inaccurate. On the left, you see the target, you see the overlay of the Unfold heat map, but you can see the green line would have been the 10 millimeter margin and left some of the tumor untreated. Now you'll notice there's a biopsy core on the left at the bottom, which falls outside of the 10 millimeter margin. So I'd like to think many of us would have tailored our margin accordingly. When comparing the data, if you look at the ROI and you apply the 10 millimeter rule, Compared to whole mounts, that would encompass the tumor in this study in about 80% of cases. If you use the default AI margins, it improves to 90%. And the confidence level correlates quite well with the predicted negative margin rate. So I think this is the first of probably many future efforts to use technology to better model the tumor within the gland and mitigate some of the risk of margin failure we observe. Now, how do we find recurrence after we've treated? Well, we all know there are simple parameters we can use: PSA kinetics, imaging, and biopsy. I think microultrasound will be a very interesting tool to study in the future to see how prostates look under ultrasound after treatment. That may be a way that we see subtle tumor under treatment, and of course biopsies. What our experience really has taught us to date is a few things, I think. One is that the initial PSA drop can be predictive of the durability of response. I think there was a nice body of work from the UCL group where they showed that when PSAs dropped after partial gland HIFU more than 80%, that was a better predictor of durability. An insufficient drop of 50%, as an example, meant over time a greater likelihood of recurrence. I will say, though, that slow rising kinetics are difficult, I think, to interpret because they may reflect over, and I'm talking about over 5 to 10 years of follow-up, it may reflect gland growth over time, or it may reflect recurrence. And so you have to be cautious of PSA rise, but expect it to some degree in long-term follow-up. My own observation with cryo is that there's a precipitous drop in the PSA, and then over the first few years, a recalibration. Perhaps the gland is recovering from the insult, and the PSA goes up a bit. I think MRI remains the essential mainstay for monitoring focal ablation, particularly when it's MRI-driven focal ablation. In early follow-up, I think MRI has a strong positive predictive value, but not a perfect negative predictive value. And so there's been a lot of talk here and at the Focal Therapy Society meeting about, do you need to biopsy if the MRI looks fine? I would dare say that I think that's somewhat energy specific. I think in the case of cryo, because we use larger ablations, it sort of is self-fulfilling that the in-field recurrence rate will be lower. But I still tend to do biopsies in early follow-up because I think it allows me to accurately select who needs retreatment. In long-term follow-up, I think MRI retains strong sensitivity for recurrence. I think the positive predictive value declines, partly because we don't have a good scale. So I was very pleased to see Dr. Shah was saying we're going to see something very soon, which is a scale specifically for assessing recurrence in this setting. But I think the positive predictive value declines. And routine biopsy, in my mind, is not warranted in long-term follow-up unless we see changes on the MRI or concerning PSA kinetics. A few things to remember for those of you starting out a program. PIRADS cannot be used to assess the treated region. This is stipulated in the PIRAD document. We've tended to use over the years a 3-point scale: no abnormality, abnormality which is likely treatment effect, or abnormality which is suspicious for residual or recurrent disease. You can use PIRADS, in my opinion, for a new tumor that develops outside of the treated field, but not within the area of treatment. Very early imaging, which is a week after, we've seen a lot of those images here. It's very good for assessing the size and confluence of your ablation on the DCE, but it's not very good at telling you whether there's residual tumor there or not. I think that comes from imaging at a more delayed interval. This would be an example of a 1-week MRI, which is done a week after, in this case, 2CAD PDT, and you can assess the size and contour of the ablative cavity. So how do we do this in follow-up? Well, this is an example of a patient with a right peripheral zone tumor that I treated with focal RFA probably about 10 years ago. And achieved what I thought was a 10 millimeter peripheral zone margin. You see the 1-week image shows a nice cavity. What happens at 6 months, the ablation cavity goes down to a small shrunken scar, the capsule retracts, and the surrounding parenchyma collapses in. Why is that important? Well, when we go to do a biopsy here, we're really sampling the margin, aren't we? We're not limiting our core to that tiny treatment zone. So that's why I say it's difficult, in my mind, to distinguish margin failure from infield failure. It's a regional failure in the area that you wanted to treat. I will say that in general, metastatic recurrences have been rare in my practice, but I do have them. I've had patients come back with nodal metastases. Usually it's been within the first 2 years of follow-up, and I therefore think it's due to poor baseline staging. In higher risk patients, larger tumor volumes, GG3 disease that I'm considering now, I tend to use PSMA PET to try to mitigate this risk to some extent as compared to before. Regional recurrences, which are in-field, those are, I think, simply technical errors, and you could try again to retreat. Sometimes you'd need to use a different energy source because of the deformity of the tissue, and maybe because they're refractory to the first, you should try something else the next time. Out-of-field recurrences I manage according to the timing. I think if they have a delayed out-of-field recurrence more than 2 years, that's a good focal candidate. If, on the other hand, they have an early out-of-field recurrence, to me, that's something wrong with the biology. We know there are patients who genetically progress rapidly on surveillance, and those are people that I'll usually convert to radical treatment. To give you a sense of that, this is not updated data, but at one point we looked at our patterns of relapse in men who had achieved at least 3 years out from partial gland ablation, and what you see is that I select people pretty early for reablation, whereas time to radical treatment is much longer. These people often come back with progressive disease at a later interval, in my experience. This is an example of a poorly selected candidate. Patient drove it a bit, but you see he has a very large tumor on the right. We treated him with HIFU. You can see we had a nice posterior destruction, but a cap of anterior tumor that probably was too far out of the reach of the HIFU gland. But here's an example where MRI clearly shows residual disease. In this case, this is a gentleman with a smaller tumor in the left posterior medial apex that I treated with HIFU, or cryo. And in follow-up, you see on the right that we had a nice destruction of the posterior lobe, contour deformity that we like to see, shrinkage of the lobe, but in the apex he's untreated. So this is a targeting error. We've missed the tumor at the edge of the ablation, and he is somebody that needs retreatment. Now, extraprostatic occurrence is rare, but this alludes to something Professor Hamdi asked me yesterday. What about the risk of ECE, and how do we manage that? So this is a gentleman who came to me with a right posterior tumor in 2018. You can see it here. I treated him with a focal for GG3 disease. PSA is a bit high, 13, but we treated him with focal cryoablation. In follow-up, we see the lesion disappears, capsule retracts, midline shifts. That's an important consideration for you when you're doing your biopsies, that the treated lobe is atrophic relative to the non-treated lobe, and so you have to tailor your biopsy accordingly. Biopsies were negative, but now by 2020, his PSA starts to rise, and repeat imaging shows a clear tumor localized within the neurovascular bundle. And you can see on the biopsy, we see cancer intermingled with nerve and fat. So this was ECE that was undertreated at the time of treatment. And this is a real challenge now to go back and salvage. I did a radical prostatectomy on him. He recurred after that. I radiated him. So, this is not a good outcome. Sometimes you don't see the recurrence, and in those cases, you can use PET. This was a gentleman that I treated with focal cryo in 2013. His pretreatment PSA declined from 7.9 to 0.8. But then over 5 or 6 years of follow-up, his PSA just kept rising slowly, like I was talking about before. MRIs didn't show recurrence, so I got an Axumin PET because I didn't have PSMA in those days. And lo and behold, there was uptake in the left anterior lobe. I biopsied him. I only found a fair amount of GG1 in the region I had treated, but because his PSA was rising, we retreated him. and now he is 11 years out with stable low PSA. So final thoughts, managing relapse. When do you give up on focal? Well, I think the disease risk matters to a certain extent. If it's a higher risk patient, you should be throwing in the towel sooner if it doesn't work. Don't close the window on curability by puttering around with retreatments. Infield margin recurrence, though, particularly if you pick it up early on a follow-up biopsy, 6 to 12 months, very amenable to reablation, sometimes requires an alternate energy source. Out-of-field recurrence, early out-of-field recurrence, assess the baseline imaging. If it's missed, if it's something that was there all along, you could probably retreat it. If it's new, this patient has aggressive disease, and I think you should treat their whole gland. And finally, if their disease risk is progressing, then consider radical therapy. So in conclusion, recurrences are an intrinsic component of focal therapy management. Risk is mitigated by careful tumor assessment, margin planning, choice of ablative energy. Careful follow-up allowing early identification of recurrence allows you to retreat them in most cases. And margin failures, again, most common. We expand the initial treatment, that margin failure rate will go down. Thanks very much.